So hi everybody, my name is Alexandru Mischie. I'm a cardiologist working in Montluçon, France. I am the chair of the telecardiology working group from the ISFTH, which is the International Society for Telemedicine and E-Health. And tonight we have the pleasure to host an exceptional webinar entitled Tips and Tricks in Atrial Fibrillation, All You Need to Know from Medical to Interventional Treatment. I have the pleasure to host the webinar with my magnificent colleague, Annabelle Volman, which I will hand the word right now. Hi, Annabelle, how are you?
Thank you so much, Alex, and welcome everybody to this wonderful conference and webinar. I'm so excited to welcome our speakers, which I will introduce in a few minutes. But I just wanted to say that this is such an important webinar because, as you know, atrial fibrillation affects so many people globally. There's about 37 million people that are affected by atrial fibrillation, and it's only increasing. So we really need to figure out how to prevent this disease that affects so many people. I was just reading today that there are 6 risk factors that were found to increase AF deaths, and that includes the usual high blood pressure, specifically systolic blood pressure, high body mass index, alcohol use, smoking, a diet high in sodium. But interestingly, I found out that lead exposure is one of the causes of atrial fibrillation deaths. So that's a new risk factor that I just learned. And maybe we can talk about that. But we're going to talk about our prevention of atrial fibrillation, also when to refer a patient for atrial fibrillation ablation by Dr. Russo, and also the whether we should act early for ablation by Dr. Amara. And then Dr. Knight will tell us some of his tips and tricks about atrial fibrillation and left atrial appendage occluder. So we're going to start with Dr. Christine Albert's talk on prevention and medical treatment of atrial fibrillation. And unfortunately, Dr. Albert could not be with us because she has another speech or talk to give, but she was very kind enough to give us a recording of her talk. So I'm going to introduce Dr. Albert. She is the current president of the Heart Rhythm Society and the chair of Department of Cardiology at Cedars-Sinai. She is the Lee and Harold Kapelovitz Distinguished Chair of Cardiology at the Smidt Heart Institute. So Alex, you can play her video.
Hi, I'm Christine Albert, and I want to thank the organizers of the meeting for asking me to give a brief overview of prevention and medical treatment of atrial fibrillation. I'm the current president of the Heart Rhythm Society, and I'm at Cedars-Sinai Medical Center. These are my disclosures. As we all know, atrial fibrillation is the most prevalent arrhythmia, and the incidence of atrial fibrillation is increasing worldwide. In 2010, it was estimated that 33.5 million people have been affected with atrial fibrillation, and estimates from 2016 show numbers upwards of 43 million. So this is continuing to grow across the globe, and for that reason alone, we really do need to focus on prevention. However, there's other reasons that we need to focus on prevention, in that once you develop AF, the morbidity associated with it is quite substantial. We all think of stroke, and that is a 4 to 5-fold increased risk of stroke associated with atrial fibrillation. However, there's probably increased risks of dementia, heart failure, which is a very strong risk factor, 5 to 10-fold increases of risk of heart failure after you develop AF, 2 to 3-fold risks of MI. There's also an increased risk perhaps of kidney disease, and there are even a bunch of studies now suggesting that there's an increased risk of cancer after developing atrial fibrillation. And all of this amounts to a 1.5 to 2-fold increased risk of mortality in patients who have atrial fibrillation. So we do need to focus on prevention. Now, there have been a number of epidemiologic studies, multiple cohorts in the United States and across Europe, that have shown that there are multiple risk factors for AF. So we do have the ability, perhaps, to prevent blood pressure, weight, sedentary lifestyle, alcohol, smoking, diabetes, and perhaps sleep apnea are all related to the development of atrial fibrillation. And it's estimated that about 50 to 60% of AF risk could be accounted for by these AF risk factors. So suggesting that if we optimized, we would be able to prevent AF. Now, just to bring you a few caveats about the strongest risk factors, blood pressure is one of the strongest risk factors for AF in the modern era. And there are data from our group and also from others suggesting that even low 130 to 139 systolic blood pressures are associated with elevated risks of AF. And so therefore tight control may also prevent AF, as has been shown to prevent other endpoints. With respect to all of the risk factors, BMI is a very strong risk factor, and this is shown across multiple cohorts. This is just one meta-analysis, and you can see the number of studies all showing the same thing, that there's about a 4% increased risk of AF with each kilogram. And there have been studies showing that if you lose weight, you can lower that risk. In addition, when you look at genetics, there's actually a suggestion that the risk may even be higher for body mass index, 9% risk with the gene scores associated with AF compared to those 4%. So it's a very, very strong risk factor. Apart from body mass index, exercise, which is one of the ways that we help to control body mass index, is independently related to AF, and is actually there's an interaction with body mass index, such that at every stage, if you are able to not be obese and to be physically active, you're really going to have a very low risk of atrial fibrillation. Now, alcohol is also related to AF in the population. These, again, multiple studies showing this very consistent associations that about 1 to 2 drinks a day is where you start to see the most risk. But there are recent studies published, about 107,000 patients, where you can see the risk even goes up at very small amounts of alcohol intake. So again, these are all ways that we can help to modify the risk of atrial fibrillation. Now, what about medical treatment once atrial fibrillation develops? Obviously, we want to try to prevent those comorbidities, and we also want to relieve symptoms. And the ESC guidelines, which were just published, have a nice diagram here, which shows that it's really not one type of treatment. We need to optimize stroke prevention. We need to take care of the symptoms with rate or rhythm control. And then we have to manage all of those cardiovascular risk factors and comorbidities that I just talked about for prevention in patients with atrial fibrillation. And again, multiple other layers to that, as you can see in the slide below. Now, with regards to managing stroke risk, we all know that there's been now, I think, 5 studies, randomized trials of novel oral anticoagulants. And when you put them together in meta-analysis, and this is one, you see lower risks of hemorrhagic stroke and intracranial hemorrhage, with about similar risks of ischemic stroke, or maybe even lower. So for that reason, in 2020, both the ESC guidelines and the ACC, AHA, HRS guidelines all recommend NOACs as first-line therapy rather than warfarin, except for patients who have prosthetic mitral valves or moderate to severe mitral stenosis. And both guidelines are in agreement that if you have a CHA2DS2-VASc score of 1 if you're male or 2 if you're female, that you can consider oral anticoagulation, but if it's over 2 as a male and over 3 as a female, you should undergo anticoagulation. And the ESC guidelines has some more data about using the HAS-BLOOD score as a way to assess bleeding risk. Now, what about antiarrhythmic drugs, controlling symptoms? So in general, when we think of rhythm control, we think of controlling symptoms, and there is some data now to suggest that there may be benefits outside of just symptoms. But in general, if symptoms are thought to be related to AF, then again, you would normally start with some rate control, but in patients who are younger, have a tachycardia-mediated cardiomyopathy, have no or few comorbidities, there's a temporary event, so you think you may be able to actually, you won't have the AFib come back. Those are all patients you want to pursue rhythm control probably early on. Now, in addition, for the antiarrhythmic drugs, remember that it's not just antiarrhythmic drugs that we're treating these patients with. It's important for us to treat for their underlying comorbidities. So for their LV dysfunction, for HFrEF and HFpEF, there are drugs that we should be choosing and treating, as you know, ACE inhibitors, ARBs, MRAs. Now, with regards to antiarrhythmic drugs, again, you can use the 1Cs in none or minimal signs of structural heart disease, but when you start to have some structural heart disease, you're going to amiodarone and dronedarone, and when you have HFrEF, pretty much amiodarone. And again, sotalol has a 2B indication with a lot of caveats about monitoring on these patients. Now, I mentioned that there is some data about using these drugs even when there aren't symptoms, or at least pursuing a rhythm control strategy, and that's the EAST trial. And you can see in these patients where they pursued an early rhythm control strategy, there was a benefit on a combined outcome of death from cardiovascular causes, hospitalization with worsening of heart failure, and acute coronary syndrome. And you can see that most of these patients were actually treated with antiarrhythmic drugs and not necessarily ablation. And you can see the types of drugs there. So maybe we should be thinking about this earlier, but this really hasn't made it to guidelines just yet. Now, with regard to the third pillar, taking care of the risk factors. So there's a lot of data now that modifying weight and cardiovascular risk factors reduces AF recurrence. And this is one study that started all off from Prash Slander's group, showing that patients who lost a significant amount of weight had a reduction in both their symptom burden, symptom severity, and also the burden of atrial fibrillation. This trial that was recently published in the New England Journal actually tested alcohol abstinence. And you can see if you abstain from alcohol, you are going to have less atrial fibrillation, although it's a very hard thing to ask our patients to do. And there are observational studies that suggest if you do these risk factor reductions and modifications, that you might reduce some of these hard outcomes. So again, this is just one study that I was involved in, where we showed that if you had optimal risk factors, your risk of developing heart failure when you have atrial fibrillation was markedly reduced, over 80%. And ablation, which we're going to hear about later, risk factors help to improve the outcome of ablation modification. So now these guidelines, lifestyle recommendations have made it into AF guidelines for the AHA. It's really focusing mainly on weight loss, AHA, ACC, FHRS. And the ESC have a number of guidelines here talking about more than that, about blood pressure control, and being more specific about alcohol and physical activity. So in summary, cardiovascular risk factor and lifestyle modification are critical for both prevention and management of atrial fibrillation. Greater emphasis on earlier treatment with rhythm control strategies is emerging, and NOACs are the first line for stroke prevention, except in those with prosthetic valves or moderate severe MS. And to make an impact on the morbidity and mortality from AF, a more comprehensive focus beyond stroke prevention is needed. Thank you for your attention.
Thank you so much. Alex, I don't know if you know, but we could not see the slides move. We will make sure that the slides are moving when we present the recording. Our next speaker is Dr. Andrea Russo. She is going to speak to us about indications for ablation. As Dr. Alberts mentioned, lifestyle changes are now indicated to prevent atrial fibrillation, but when they do have atrial fibrillation, I think that we wait a little too long to send them for ablation. And with the new data that's coming out of many of the studies, I think there is a lot of enthusiasm for atrial fibrillation ablation. So with that, I would like to introduce Dr. Andrea Russo, who is the past president of the Heart Rhythm Society, and she's a professor of medicine at Cooper Medical School of Rowan University. She's also the director of the Cardiac Electrophysiology and Arrhythmia Service, as well as the EP Fellowship at Cooper University Hospital. Welcome, Dr. Russo.
Great. Thank you so much, Annabelle. Thank you for inviting me, both Annabelle and Alex, to this great webinar. I really appreciate it. It's an honor. These are my disclosures. So, why do we treat atrial fibrillation? Well, we treat it because people have symptoms. They don't feel well with it, but there's also some other outcomes we'd like to look at in terms of increasing the risk of mortality, increases the risk of stroke, increases the risk of heart failure or developing LV dysfunction or tachycardia-induced cardiomyopathy from really rapid rates in AFib. There may also be some impact on cognitive function or even causing depression. Impaired quality of life is pretty clear. People don't feel well with atrial fibrillation, and increasing hospitalizations. So, the major reason for selecting rhythm control, Dr. Albert talked a bit about drug therapy, but ablation, the major reason we really send people for ablation or do ablations is to improve symptoms. But, we do have trials, including Cabana, which is a large randomized trial that look at other big endpoints like death, disabling stroke, serious bleeding, or cardiac arrest was the primary endpoint here. You could see in the intention to treat analysis that there was no significant reduction in that primary endpoint in the intention to treat analysis, although mortality and cardiovascular hospitalization was reduced with catheter ablation. As you might imagine, there was a good amount of crossover in this study, but in particular, 9% of patients randomized to ablation weren't even ablated. If you look at the per protocol analysis for people who actually got ablation, the primary endpoint was significantly reduced. Whether or not you think it's valid to look at this type of analysis, that's what we saw or they saw. If you look at specific subgroups in the intention to treat analysis, there's certainly certain subgroups you get an idea. Maybe, although it's not powered to look at these subgroups, maybe younger patients might benefit more. Maybe men might benefit a little bit more than women, and we'll get more into that. In paroxysmal patients, in this study, in persistent, they actually both, benefited, which is, different than some other studies. But the heart failure group is also something we'll look at in a little more detail, that there may be a tendency for people with heart failure or worse heart failure to benefit more. So what about AFib recurrence? Well, if you look at a meta-analysis of prior studies, one procedure we have to know, we tell patients when we're considering an ablation, this may not be, the only time you come to the lab to have a procedure. So there's a lot of heterogeneity in the population with just a single procedure, but with multiple procedures, you could see even long-term success is much better. Depending on, the study and the population, sometimes, people have more paroxysmal AFib, and we'll hear more about early on treatment of AFib may do a little bit better than people who have non-paroxysmal AFib in some studies. So what about, recurrent AFib, right? Is, in terms of Cabana, we know that for sure, ablation was much better in maintaining sinus rhythm than drug therapy. What about quality of life? And that's something that's really important, patient-reported outcomes. When you look at quality of life scores, or you look at symptom severity scores, ablation did much better than drug therapy in Cabana. What about age? I alluded to that. Well, this was just a single center study, but they did look at age and again, older patients, for a variety of different reasons, potentially were more likely to have recurrent arrhythmia after ablation than younger patients. In addition, in Cabana, there was that little, tendency to maybe think younger patients might do better also in terms of even the primary endpoint. Now, what about, sex? Well, in reality, it doesn't really make any sense to compare men and women per se, because if you're seeing a patient in the office, they're either male or female. So for each of those, so what we decided to do in Cabana was to look at ablation versus drug therapy and, what improved recurrence from AFib. And you could see that in both women and as well as in men, the time to first AF recurrence was significantly better for ablation than for drugs. So that is an important finding. What about heart failure? And this is the group we really have a lot of really robust data. Castle AF randomized patients with, these were sicker patients, lower ejection fraction and heart failure. They also had ICDs. And the primary endpoint was death or hospitalization for any cause or hospitalization for worsening heart failure. You could see that patients who received ablation did better than those who got medical therapy. And there was a meta-analysis of many of these trials in heart failure patients. You could see overall, the meta-analysis shows that same finding in terms of heart failure hospitalization reduced with ablation compared to drug therapy or control. And all-cause mortality on top of that was reduced with ablation in this population of patients with heart failure than in not getting ablation. And if you look at Cabana, actually, this just came out online, and it's basically looking at the same kind of thing, but looking at the primary endpoint in Cabana. And this is a subgroup analysis, a post hoc analysis, but showed there was a significant benefit of ablation versus drug therapy in patients who received ablation in this particular study, randomized study. But as in a lot of things we do in medicine, patient selection is key. And alluding to some of the things already, AFib duration, and I'm looking forward to hearing more about that. Getting AFib earlier gives you a better chance of maintaining sinus rhythm. And that kind of overlaps with some of these things, before you get remodeling of your atrium, the atrial size, or even the presence of atrial fibrosis, the type of AFib, other factors we talked about, age and sex and other, structural heart disease may have a role. But there may certainly be a point of no return in some patients. And this is a pretty big atrium, but a volume of over 130 cc's, you may just as well say, hey, there's a point of no return. Chances of getting you to maintain sinus rhythm are pretty low after your atria gets to be huge. And then others have looked at atrial fibrosis. So the green part here is the amount of fibrosis in the atrium. And if you're in this group here, stage 4 fibrosis, you could see the recurrence rates. This study looked at 1-year recurrence, where it was much higher if you had a lot of fibrosis than if you didn't. And this held true up to a 5-year follow-up. So what are the recommendations? What are the guidelines? I wanted to give you a background of how we got there. So I'll show you the US recommendations and then the European guidelines, ESC guidelines. You can see here that for the heart failure population, pretty robust data. The US guidelines say that AFib ablation is reasonable for selected patients with symptomatic heart failure and AFib who have a reduced ejection fraction to potentially lower mortality and reduce hospitalization for heart failure. In the European guidelines, actually, first-line therapy, a recommendation, a class 1 recommendation, that if you think the patient has a tachycardia-induced cardiomyopathy, meaning the AFib caused the cardiomyopathy, that you should go ahead and ablate that patient and make them better. Now, again, a 2A recommendation, class 2 recommendation in selected, it's not every patient who has heart failure. Sometimes, AFib occurs at an end-stage process. In selected patients, consider the patient population before, doing an ablation. But some good data in some of these patients. What about if patients have failed drugs? The US recommendation, I want to say this was, the recommendation was a guideline, was a consensus document recommendation prior to publication of Cabana, but the paroxysmal patients, you failed or were intolerant to drugs, class 1 recommendation, high level of evidence in the US guidelines as well as in the European guidelines. Now for persistent patients, maybe it'll be different because, that was before Cabana was published. It was a 2A recommendation. The European guidelines give it a class 1 recommendation, level of evidence A for persistent AFib, but they qualify, which I really like, actually, without major risk factors for AFib recurrence, and a little lower level of recommendation here for persistent AFib with major risk factors. So look at your patient, the particular patient. And what about first-line therapy? Well, the US guidelines, 2A recommendation for paroxysmal or for persistent atrial fibrillation as a first-line therapy. Similar class 2 recommendations, 2A or 2B for paroxysmal or persistent patients, again, qualifying, but considering other things like patient choice and the specific situation of the patient in terms of benefit and risk. Catheter ablation, also they qualify here, and we do this clinically, is patients who might need, it's either a pacemaker and we have to put a device in, and that's lifelong living with the device because of drugs that we need to maintain sinus rhythm or control rates. You might want to consider ablation in that situation. But what we don't consider ablation for is to get people off anticoagulation. And we all see these patients in the office. In fact, we don't have any data yet, and there's some studies going on, but to maintain even if you maintain sinus rhythm for 6 months or a year, right now, we still recommend anticoagulation based on the guidelines, based on risk factors for thromboembolic complications, or appendage closure might be another option for some of these patients, but don't do an ablation to get off of anticoagulation. So in summary, this is really, it can be a complex decision-making process. We want to look at long-term control for symptomatic AFib. That's the strongest evidence. We're going to help improve symptoms. We might help improve heart failure in that population, improve, outcomes in the bigger outcome endpoints there. But, drugs just don't work really well. They're limited drug choices in heart failure patients. They can have negative inotropic effects. There's a high recurrence rate. There could be proarrhythmia and side effects. But they're, class 1 or 2 recommendations but we have to tell patients, you may need multiple procedures and there are some acute risks or complications. Thank you.
Thank you so much, Andrea. That was really excellent summary of what's going on in atrial fibrillation ablation right now. I have some questions for you, but I think we'll wait until the end. And for the audience, please ask your questions in the Q&A, and we'll ask those questions at the end. But I'm going to ask Dr. Mischie to introduce our next speaker.
Thank you so much, Annabelle. Thank you to all the previous speakers. So you will be able to access the recording of the webinar with the recording of Christine Albert in the replay. We will send you the link. Also, I wanted to inform all of you that we had around 700 subscribers with around with much less live activity, but I think people will see the replay tomorrow. So without further delaying, I have the pleasure and honor to introduce to you Dr. Walid Amara, which is the Director of Cardiac Electrophysiology at Hospital Montfermeil in France, and is the President-elect of the CNCH Association, the Cardiologists Medical Association in France. Hi, Walid. How are you?
Hi, everyone. Thank you for inviting me. And now we speak about argument about area management. These are my disclosures. So, of course, we rely mainly on the new European Society of Cardiology guidelines. And as you see, one of the deciding pathway is to go through this ABC. And here we go through the B, which is better symptom control. And in better symptom control, you have the optimization of the weight, which can be associated with the rhythm control strategy. And the rhythm control strategy should be considered. And we try to explain you when and how should be the evolution actually regarding rhythm control strategy. This ABC was based mainly on one article coming from Greg Lip that was published in 2017, and you find the same ABC pathway there. And if you go through the European guidelines, you see that regarding weight control, of course, weight control is background therapy for most of our AF patients. Even, for example, if you are giving flecainide, you should now combine with beta blockers, which is a class 2 indication, which is not in the previous ones. And it can be the first choice for some patients, mainly the oldest patients, maybe the patients with minor symptoms, but also is a therapy in case of a failure of rhythm control strategy, and when you think that the benefit of restoring sinus rhythm is higher than just controlling the rate. And if I go through the same ESC guidelines, you see that rhythm control strategy is recommended for patients with symptoms to control the symptoms that improve quality of life, which is a class 1A indication. And here again, if I go through this 4S coming from the ESC guidelines, you see the second S is symptom severity, and you should assess the symptom severity, and the third S, which is the severity of F burden. And these two criteria help us to identify the patient that should be good candidates for rhythm control strategy. And if I go through the same algorithm coming from the guidelines, you see that if the patient presents symptoms, the majority of them are candidates for a rhythm control strategy, particularly if they are for younger patients, particularly if it is a first experience of atrial fibrillation or short history of AF. And here we will speak about early rhythm control strategy. If you think that and you spoke about heart failure, about tachycardia mediated cardiomyopathy, if you have some normal left atrium, not so dilated left atrium, for example, if you think that the rate control strategy may be difficult to achieve, of course, for some patients that have a temporary events, I don't know, pneumonia, hyperthyroidism, or something like that. So, of course, in this case, you may choose a rhythm control strategy. This is an old figure coming from an article in Circulation 2004, and you know this concept that atrial fibrillation begets to AF, and that's an argument to say, okay, maybe we should do our action very early towards rhythm control strategy. And you know, each of us as arrhythmia specialists were disappointed when we had this AFFIRM trial published. And you see that there were no differences between rhythm and rate control regarding mortality. But remember that if you go through the subgroup analysis, that normal sinus rhythm was associated with a better prognosis, but antiarrhythmic drugs was associated with lower, with a higher mortality, and that get us thinking that maybe we should think about other strategies, maybe actual antiarrhythmic drugs, and of course about ablation. If I go through the different events, you see that there were no, on the right, no differences between the two arms regarding death or start de pointe, etc., or MI, etc. And of course, this arrived to something like EAST-FNET4, which is, may I tell you that maybe for me is the AFFIRM trial on the actual era. So in early AF, they take atrial fibrillation with less than 1 year of duration of first episode documented of atrial fibrillation, and they are randomized between an early rhythm control strategy, which includes anticoagulants if needed, and the antiarrhythmic drugs, and in some cases, but only a minority of cases, that had atrial fibrillation. And you have the usual, what has been called here, the usual care strategy, which is mainly a weight control strategy with only lower number of patients that had antiarrhythmic drugs. You see here that it is around 2,800 patients that were randomized in 11 countries. And you see on the left of the screen, the patient that received the early rhythm control strategy. And you see that this was mainly based on antiarrhythmic drugs. And you see that maybe 36% were receiving flecainide, 17% ranitidine, 20% amiodarone, and only 8% ablation. And at the end of the follow-up of the 2 years, not far from 80% of the patients had received an ablation. And you see the antiarrhythmic drugs maybe represent 50% of the cohort. And in the control group, you see that only a few number received antiarrhythmic drugs. 7% had an ablation, and maybe only 5% of this cohort received antiarrhythmic drugs. When you see this primary endpoint, and this is a composite endpoint that associated cardiovascular death, stroke, hospitalization for heart failure or for acute coronary syndromes, you see that there were a significant difference in favor of the early rhythm control strategy, 21% reduction, relative reduction, and you see even on cardiovascular death that there were a significant reduction of cardiovascular death. You see that, of course, a higher number of these patients on the early rhythm control strategy were in sinus rhythm. The odds ratio was more than 3. If you receive an early rhythm control strategy, you are in the majority of the cases in sinus rhythm, which was not the case if you are on the weight control. And if you go through the side effects, you see that the number of side effects was similar, but maybe I would say that you see that the percentage of stroke, 2.9% on early rhythm control and 4.5% in the regional control, that was not significant. But you see that, I don't know, I can imagine that, as you said, I don't propose ablation or antiarrhythmic to avoid anticoagulants, but something to think about that in the future. Of course, maybe in EAST-FNET4, we use modern strategies. And you know, in the ESC guidelines, now the sotalol has been disclassified as a 2B indication because of potential side effects. And I believe that this is also something is this cohort of more than 25,000 patients followed for 3 years, and you see that with follow-up around 8 years, you see that the majority, that the lower mortality is observed with rhythm control strategy. You see as well, this is a registry that has been done by John Cam, 5,000 patients with early AF less than 1 year. It's not randomized, and you see here that cardiovascular death was lower in the group receiving a rhythm control strategy versus rate control strategy, but it's not randomized. You see as well that if you go to the subgroups analysis in the AFFIRM trial, that some drugs did less good results, and especially you see here for sotalol, which is now disclassified in our ESC guidelines. And to look to dronedarone, that I found this sub-study of Athena, and you see that if the treatment was administered in the 3 first months of atrial fibrillation, the rate of cardiovascular hospitalization or death was lower in the dronedarone group. And if you look to patients that received treatment after 2 years, the difference was not significant. So it's something interesting. And this arrived me at the end of my topic to new trials, and that will be, I know that the next topic we speak about ablation as well. And I found it very interesting, the early AF that was presented at the AHA conference. It was really interesting because in this trial, they included patients very early in the disease, and they randomized them between 2 early rhythm control strategy. One is ablation and one is antiarrhythmic drugs. And you see that these patients were naive from antiarrhythmics. So you can imagine that these patients were very early seen in their pathology. You see the characteristic of the population, and they were, as you see, followed by reveal links. So you can follow here the sinus rhythm and recurrence of atrial fibrillation. And as you see here, a specific population is the young population of ablation, less than 60 years old. But if you go to a history of atrial fibrillation, you see that the median duration for the first AF diagnosis is 1 year. And so maybe some early, not the first months, but less than 1 year for the majority. For more than 50% of the patient had less than 1 year evolution of their atrial fibrillation. And I found it very interesting that you can do your strategy very early. And here you see that ablation did better regarding freedom from atrial fibrillation. 57 versus 32% were free from atrial fibrillation at 1 year follow-up. And even if we see to the atrial fibrillation burden is really lower on the ablation group. Of course, you should accept some side effects. This was done with cryoablation. So you have this issue of phrenic nerve injuries, which is less than 1% of the ablation, and in majority of the cases is reversible. Of course, some pacemaker due to bradycardia, but I don't think that this is due to the ablation by itself. And of course, there are some poor arrhythmias like wide compressed tachycardia that has been observed on the antiarrhythmic drugs. The rate was not significantly different regarding serious adverse events, but for any safety endpoints, it was lower on ablation than on the group of antiarrhythmic drugs. So my message is that I really believe that atrial fibrillation begets to atrial fibrillation, and that early rhythm control strategy can be achieved with good safety using antiarrhythmic drugs for some patients and catheter ablation for others. And all these recent data suggest that maintenance of sinus rhythm is associated with a better prognosis. Thank you again.
Thank you, Dr. Amara. That was excellent. Dr. Brad Knightley and I were involved in several antiarrhythmic drug studies together, and we knew all the problems that came with it. So we appreciate the new recommendations to ablate early. But I love your take on what happened with the AFFIRM trial, that since we initially didn't find any difference between the two strategies, that we had to find something better. And it really encouraged people to do better. And I think that I love your take on that we had to strive for better outcomes for our patients. And without further ado, I'm going to introduce my colleague here in Chicago, in frozen Chicago, Dr. Bradley Knight, who is the editor-in-chief of the Journal of Cardiovascular Electrophysiology. He is also the director of cardiac electrophysiology at Northwestern Medicine and the director of the Heart Rhythm Center at the Bluhm Cardiovascular Institute. He is also the Cooley Distinguished Professor of Cardiology at Northwestern, and he is going to talk to us about tips and tricks of catheter ablation and left atrial occluders for atrial fibrillation. Thank you, Bradley.
Great, thank you very much. Thank you, Annabelle. Thank you, Alex, for the invitation to participate. I'm going to focus primarily on the technical aspects of catheter ablation and left atrial appendage closure, but really in the context of the talks that we just heard. These are my disclosures, which are fully available at University Northwestern's website. I want to start just briefly with some general tips that probably apply to both topics. I can't talk about how to do AF ablation and appendage closure in 10 minutes, but I do have some general thoughts. We just heard a lot about patient selection, and maybe we'll have time in the discussion part, but I saw a patient recently who had his first episode of AFib and was admitted to the hospital, spontaneously converted, was told he needed to start on an antiarrhythmic drug, wasn't interested in that, and then was told he had to have an ablation procedure. And if you actually, Walid's presentation would suggest that that actually would be consistent with the European guidelines. So I'm all for early intervention, but I think we can't push it too far. I think we should look specifically at the natural history of some of these patients who present with their first episode of AFib. And I think the goal really should be to improve symptoms. And after a single isolated event, maybe we should just continue to observe the patient. Most importantly, I think related to this topic, it's good to have a very experienced EP lab team. We know that outcomes don't just depend on the volume of the operator and the physician, but the center itself. Having good industry support to provide reliable support during the procedure is also useful. Again, I think there's plenty of data that high volume procedural experience and expertise is critical to good outcomes. I think that regarding these two topics, both have something in common, which is transeptal catheterization. And although everybody who does these is pretty good at doing transeptals, there are outliers, there are difficult cases, and I think we need to have experience with challenging transeptals. And one thing I've noticed, I think, with left atrial appendage closures, they tend to be older patients with more tortuosity in the vasculature, and getting transeptal catheterization successfully can be even a little more challenging. This just emphasizes how they're not all easy. You can see a very thick intraatrial septum in this young man who had 4 catheter ablations in surgical maze, who came in with recurrent left atrial flutter, and we performed transeptal catheterization. But you can see even with ICE guidance, there's a very thick area. There was not a thin fossa ovalis to target with ablation. Our routine approach for reproducibility and quick successful transeptal puncture is to routinely use a powered, in this case, Baylis powered RF transeptal needle.
Alex, can you hear Brad?
Yes, so no, I think Brad got disconnected.
Yes.
Okay, so let's wait a little bit and then he will reconnect.
in the meantime, we can ask some questions.
Yes. Okay,
Okay.
so Brad will reconnect shortly. Yeah, so meanwhile, I would just like to thank Walid, which is in vacation in the Alps. Thank you for taking the time also, Walid, and thank you, Andrea, and thank you, Annabelle, once again. Yes, maybe Annabelle, if you could address some questions, because this is your domain of expertise. I'm not an electrophysiologist, so please go ahead.
Yeah, so I wanted to ask all three of you actually, and I'll ask Brad when he comes back, but what do you quote as your success rate with the first atrial fibrillation ablation? And do you talk about the potential for another one? Hello, Brad. We lost you and you're muted. Thank
Sorry,
you.
I don't know what happened, but if I can continue where I left off, maybe.
Yes, please do.
Yeah, you should share your screen.
I will share
Right.
my screen.
It happens, no problem.
Okay, let me get this in the shared mode. Okay, everything you can see now?
Yeah.
Yes.
Yeah, I'm sorry. So I was referring to the fact that we routinely use a powered transeptal needle. You can see the needle puncture here with ice guidance. Then you can see the dilator cross the intra-atrial septum. We then remove the needle and add a wire in advancement so that it's safe to advance the dilator and sheath. There are several new transeptal catheterization tools that are becoming available. One is a powered wire, which has some advantages over the needle when you can get the needle across, but not the dilator or sheath for very, very difficult cases. But then you can see here in this RAO and LAO view, the transeptal wire, which is powered, as you can see in this ICE video, crosses the fossa ovalis and then can be advanced over a guide wire. So these are transeptal catheterizations common to a lot of what we do in the EP lab, as well as increasingly in the structural field. So I think it's important to have experience with transeptal catheterizations. It's important to be familiar with your tools and your devices, regardless of what you use to perform pulmonary vein isolation, whether it's a balloon or a focal RF. It's very important to have experience with those individual tools and devices. It's important to know when to stop and to switch to plan B. If you can't isolate the pulmonary vein with the cryo balloon after a few freezes, you need to be able to isolate that vein with another tool. Attention to detail during the procedure, minimizing any air issues, clot issues, access issues is critical. And then careful post-procedural monitoring. We currently have not been doing same-day discharges, but I think if you're going to send the patient home the same day, there has to be a system in place where the patient can contact you and get safe care after hours. This is a slide just to remind everybody that the pulmonary veins are the source of triggered activity and reentry in many patients with atrial fibrillation, particularly those with normal hearts. And the muscle sleeves that extend up into the pulmonary veins, as you can see here in this anatomical image of the right superior, left superior, left inferior, right inferior pulmonary veins. This is just these islands of pulmonary vein tissue are perfect substrates for reentry. This is a patient actually who had had a pulmonary vein isolation procedure about 20 years ago and did very well for many, many years, and then started having recurrent atrial fibrillation. You can see that the pulmonary veins were still isolated, but in a very distal fashion, as was common practice kind of in the early 2000s. This patient came back and had some bursts of activity below the right inferior pulmonary vein. And so a wider area antral isolation was performed, giving this subsequent pulmonary vein isolation in a more antral way. And this patient has done well. So I think it's not just the goal of isolating the pulmonary vein, but it's deciding where to make those lesions and how antral to actually go. Point-by-point ablation will always have the limitations. It's not really designed for making linear lesions. Here's an idealized lesion set from an old case using a cardio mapping system where each point is contiguous, transmural, and results in electrical isolation of the vein pairs. We know, though, that even when this is done acutely, you can have isolation. There is a vulnerability to edema resolution and reconnection. And here's an anatomical specimen in an animal model of point-by-point ablation where there was electrical isolation of the vein, but you can picture right here a potential gap that could result in reconnection. I just put this is a case from last week of a patient who had right atrial flutter and a lot of scar, no prior AF ablation or surgery, but he had had typical ablation, typical flutter in the past. And we had a very complex rhythm rotating around the superior vena cava and then through this area of slow conduction here that was targeted with ablation, and we had termination here. An additional ablation was made to make an intercaval line with subsequent block. Doing this, though, without being able to visualize these lesions requires some indication of lesion formation, and there are increasingly surrogate markers of lesion formation, whether it's an ablation index, impedance drop. There's many, many things that can be done. This is a recent animal study I did with a new dielectric mapping system, looking at different indices of ablation, where we gave lesions with high contact force and high power, and then low contact force and low power. And then when we opened the heart, you can see this intercaval line was consistent with what we predicted, where there were lesions here and no lesions here, that in this case were transmural. So point-by-point ablation is getting better. We have much better surrogate endpoints and contact force measurements. But I still think that a balloon-based system is a more logical approach if your goal is to isolate the pulmonary veins. There are 2 cryoballoons that are being pursued. The Medtronic cryoballoon has been around for a while. It's been FDA approved for several years with the 2nd generation balloon in the United States. Boston Scientific has their own cryoballoon, which is under clinical trials in the frozen trial in the United States. There are 2 RF balloons. Biosense has the Helios balloon. The Stella trial was just completed last week. We actually did our last patient 2 weeks ago using an RF balloon. The Apama balloon was acquired by Boston Scientific, and my understanding is that that trial is not going to proceed at this point, and that there will be more developments into pulse field ablation instead, is what I understand. Other balloon technologies include the laser balloon, which is FDA approved in the United States, and the hot balloon, which is in development in Japan. The newest kid on the block, so to speak, and I will tell you that at the AFib symposium this year, I looked through the program. There were 100 speakers, and 11 of the presentations were about pulse field ablation. 5 of the 10 live cases were with PFA. And I think that really shows that this is probably here to stay. Irreversible electroporation could technically make left atrial ablation and pulmonary vein isolation very quick, safe, avoiding collateral injury and resulting in durable lesions. So this is an exciting new technology. There's also ultra low temperature cryoablation, which is in development by the Adagio company. We routinely at Northwestern use cryoballoon to isolate the pulmonary veins. Again, we don't have time to go into all the details, but it's important to have many cases under your belt so that you can really be good at getting occlusions in difficult cases to get PV isolation. And we've heard already about some of the clinical trials, early AF, et cetera, but the Circa-Dose trial with Jason Andrade emphasized that although our AF ablation trials have shown improvements in outcomes with AF recurrence, what's dramatic is that we can see over a 98% reduction in AF burden in patients who may not necessarily have met the criteria previously for success. Briefly about left atrial appendage closure. In the United States, the only FDA approved device is the Watchman device. The current device that we're implanting is the Flex device, and we'll talk a little bit about the differences between those devices. The Amulet device has already undergone FDA clinical trial in the United States. They're awaiting those trial results before that will be evaluated by the FDA. In the meantime, there is the Catalyst trial, which is randomizing patients who don't have a reason to come off anticoagulation, but would prefer to perhaps not take a NOAC. So it's NOAC versus appendage closure with the Amulet device in the Catalyst trial, and in the Champion trial, we'll be looking at the Watchman device. These are all the devices that are evaluated or potentially available worldwide, including the Lariat suture snare. We have been using the Watchman Flex as of about 6 months ago, and again, the Amulet is part of clinical trials. But there are other devices such as the Wave Crest and the Lambry device, which are being evaluated. The biggest difference between the most recent version of the Watchman device, Watchman 2.5, and the Watchman Flex is the shape. It's more rectangular instead of square, which has the benefit of not requiring the sheath to be deep-seated into the appendage before it's unsheathed. And when the device comes out, it has the feet closed instead of a sharp open end. There are 2 rows of anchors, which are more in the shape of a J compared to this form. The screw insert is actually recessed in the Watchman Flex device, and there's more struts. It just feels differently. It's very easy to recapture and to reposition when being deployed. The biggest difference really is how you implant the device. Previously, if you look down here, this is how this was done. We would unsheath the device and it would expand. Often we didn't have enough room to unsheath the device. The beauty now is that you can partially deploy the device into this ball shape. You can then safely manipulate that within the appendage to target different lobes or different depths for full deployment, and then just push the device out and get a seal. So again, these ball shapes are shapes that allow safe manipulation of the tip of the catheter in the appendage. There are different sizes and shapes, and it's important to use both TEE measurements, contrast injections, sometimes ice to decide which device is appropriate. This is the Watchman reference guide. This really has everything you really need to know during a case. So I'll stop there. Sorry for the technical challenges, and thanks again for the opportunity to participate.
Brad, that was really awesome. I learned so much. Thank you so much for all that information. I love that stuff. So I'm so excited that there's so much innovation and development going on in this field. I wanted to ask, while you were having technical difficulties, I started asking Walid and Andrea the question of what do you quote your success rate is for a first ablation, and do you talk about a potential second ablation? So maybe I'll ask you, Brad, first, and then the others can chime in.
Well, we participated in the STOP-AF post-approval trial, so we have pretty solid data to answer that question for the patients with paroxysmal AFib. And I tell them that the likelihood of success at 3 years is 70% if you have paroxysmal AFib, but that's based on a very strict definition, and that many of those patients who don't meet the criteria for success are significantly improved. I'll often refer to the circuit dose trial showing that there's a dramatic reduction in symptoms. We didn't look at AFib burden in the STOP-AFib post-approval trial, so a surrogate of how many patients were doing well was how many patients needed to have a repeat ablation. And the likelihood at 3 years of needing a repeat procedure was, I think, 18% in the post-approval trial. The persistent patients, it really depends on a lot of other factors. I think early persistent patients probably do well. I tell them, in general, probably 50 to 60%, and that they may need to have a repeat procedure.
And Andrea?
Yeah, those are actually the numbers I quote also. But I also, have a caveat saying, multiple, don't think that this may not be the only procedure you have, particularly for patients who are persistent, particularly if they have, other, I'll even lower that success rate if I look and see there may be a lot of scarring. I don't know ahead of time. I'm not getting, looking at fibrosis, ahead of time by MRI in these patients, but would kind of qualify it saying you might need more than one procedure, 2 or 3 procedures potentially if you have a huge atrium, if it turns out that you have a lot of fibrosis or scarring when we go in. And then I also say, the other thing too, the definition we use for success in the trials isn't necessarily what patients think is a success, right? So they may have infrequent episodes, and if they have, we're in AFib all the time and we're bothered in and out of the hospital, and then they have one episode of AFib a year and a half later, and it's a short duration and self-limited, that to the patient would be success, whereas our definition is recurrence.
Great points. Walid,
Yeah.
did you want to chime in? I saw you had some technical difficulties there.
Yeah, no problem. I think that's really great what Andrea said, is that of course the definition of success is a very important question to address. And I remember last week one of my patients, that I did ablation, I think 3 years ago. And with his smartwatch, he said, "Oh, you know, doctor, I had one episode 1 year ago for just 1 minute." I say, "That's great. That's great. You have an excellent result." But I see, and even patient now know very well some results. You know, early AF trial has been, the patient asked me about early AF and say, "Don't look to the trials, you have an excellent result."
Exactly. Right. Great points. Thank you. Alex, I know you wanted to have somebody else ask some questions.
Yes, thank you. So just briefly, I would like to salute Dr. Pasquale Crea, which is a rhythmologist in Italy. And Dr. Crea is also our ambassador for Italy. I know Dr. Pasquale has a question for Andrea. Hi, Pasquale.
Hi, Alexander. Thank you for this kind invitation. I would like to congratulate to all speakers for this huge presentation. I have some question for Professor Russo. I would like to ask what is the role of age in indication to atrial fibrillation ablation procedure? We know young people with less comorbidity had the best chance of AF ablation success. And do you think in the practical setting we should have an age cutoff for AF ablation, like more than 75 years old could be reasonable?
Yeah, no, I think that's a great question. I actually don't use age as a cutoff. I look at the whole patient, and I could have a 78-year-old who's running and who's really active and doesn't have a huge amount of other diseases, and that patient could be in a better situation than someone who's younger. So I think we need to be careful about excluding patients. If you get into, if you're over 90, I don't think I've ever ablated anyone over 90 for sure, but on occasion, someone in their 80s, who's really active too. So I wouldn't exclude them. I haven't excluded by age, whether or not, the cost and the amount of resources in healthcare, may limit us more so, even more so in the future. I don't know. But we have to think of all the times that those patients, if they're really symptomatic, and they may be in and out of the hospital too. So I don't use age alone, let me say, but they may, if it's someone who's had AFib for 10 or 15 years and their atria is huge and they have, a lot of other comorbidities and risk factors for recurrences, that patient I would treat differently than someone who's, has really nothing else going on.
Thank you, Andrea. I would have a question for Walid, but also for Bradley and Andrea. So Walid, what do you think about weight? So I often see patients, overweight patients in consultation. So my reflex, if they have symptoms, is just to contact the electrophysiologist right away to put them on the waiting list. Should they wait, I don't know, at least 3 months or 6 months so they can lose weight for the ablation to be very efficient, or not?
My comment is that the only patient that have really a complete success are some obese patients. I have one obese patient that arrived with a heart failure, with an ejection fraction of 25%. We did ablation twice, and he changed his life. He did sport. He did an intervention for obesity, and now he is as slim as me. He do sport, and he has only now one medication for hypertension. And a few years after that, I received his brother with the same disease, atrial fibrillation, obesity, heart failure. We did the same strategy. We did operation for obesity, 2 ablation for atrial fibrillation, but he didn't change his life. So now he reduced his weight, but he's still obese, and he's in permanent atrial fibrillation. So I really believe that treating obesity is an important issue.
Thank you. Bradley, what do you think?
Well, I think there's different categories of obese patients. There's clearly evidence that obesity causes AFib. It reduces outcomes after AF ablation. There are some that are on the spectrum where if they're morbidly obese, I worry more about them tolerating a complication in the EP lab than anything else. So if the patient is so big that I don't think you could do a pericardiocentesis on them ever, I wouldn't offer them an ablation procedure. I think it's too dangerous. Then there are the patients who I think really take, I think like Walid talked about, there are patients that take your advice to heart and will lose weight and actually do very well, may not even need an ablation procedure. But as we know, most patients, at least in the United States, who are moderately obese, they've come to you for help, and the likelihood they're going to listen and lose weight, just like we see patients who smoke a lot, is low. And I think we have to be careful not to offer ablation to some of those patients where it's just not realistic. It's almost unfortunate this has become a hot topic just amongst electrophysiologists. I mean, this is really something that's a population issue that primary care doctors and others should be helping us with.
Thank you, Bradley. So maybe Andrea, a few thoughts on that?
Yeah, no, I agree with what both Walid and Brad came up, points they brought up. I think we look at obesity and it could affect a lot of other things, including atrial fibrillation. So for other reasons, and I always include as part of my initial discussion in consultation, is discussion about these, other lifestyle modifications, that treatment of sleep apnea, there is also coexisting in these patients. I think the work that Prof. Saunders has put out is really impressive, in terms of improving outcomes after AFib ablation. So it's a good thing overall. But, I certainly don't exclude someone, a lot of patients have obesity, and particularly in the United States. But, do highly encourage that they do these other measures for risk factor modification for their AFib, but for all the rest of the other problems that it can cause.
There are two questions in the question and answer, so I just want to get to them. One is, does catheter ablation decrease the incidence of functional atrial fibrillation and mitral regurgitation? Does anyone want to answer that?
Well, I'll address that. It's actually quite interesting. It does appear that I would have never thought that a fibrillating atrium could stretch the annulus, but there is data, I think, that's pretty compelling that if the atrium are fibrillating and they start to dilate, that it can not only result in functional mitral regurgitation, but also tricuspid regurgitation. And I think that may not be your sole reason to do an ablation, just like getting off anticoagulation. If someone has permanent AFib and severe MR, normal LV function, I doubt you do an ablation to correct the MR, but I think it's important for us to recognize that those can be related.
That's a great answer, actually. The other question is, how do you decide what size of watchman to use, 14 versus 16? And I couldn't understand the rest of the question, actually.
Yeah, I saw that question. Maybe I can just, as a rule of thumb, there are different sizes of Watchman left atrial appendage closure devices. The Watchman Flex has more sizes than the Watchman. The decision is made based on, usually at the beginning, looking at the left atrial appendage ostium, which can be oval in shape, and looking at the largest diameter, and then using some math or a conversion table to find out which device will result in adequate compression. There has to be some compression on the device to ensure stability. So if the goal is to get 10 to 20% compression and your maximum diameter is 19 millimeters, you might pick a 24 millimeter device. So I have been impressed with how it doesn't always work. You pick a device and it turns out it's just not big enough, or it's too big. And sometimes we do an angiogram, kind of an aerial caudal view routinely, and do manual measurements on the screen. Sometimes the angiogram is a little more precise for picking the size of the device.
Thank you so much. I know we're running out of time, and I've been asked to wrap up. So I just wanted to thank our speakers, Dr. Russo, Dr. Amara, Dr. Knight, for your time and expertise. This was such an educational symposium and webinar. So I thank you so much for educating us. And I wanted to ask one last question. I know we don't have time, but think about this for the future, is whether we should be ablating asymptomatic patients, because I worry that my asymptomatic patients will dilate the left atrium and right atrium and will cause more heart failure in the future. And I wonder if we're shortchanging those asymptomatic patients. So think about that, and maybe the next webinar, we can tackle that question. Thank you.
Thank you, everybody.
Thank you so much, Annabelle. Thank you, Andrea. Thank you, Bradley. Thank you, Walid. Thank you to all the audience. And you will be able to see this recording tomorrow. So have a nice evening. And thank you once again for your time. Thank you.
Thank you for the invite.
Bye.